thank you for being here. I know we're all busy. There's a lot of stress on our plates these days. And so I appreciate, we appreciate you taking the time out of your busy schedules to be here and learn about psychological first aid today. My name is Dr. Lauren Bonavitacola. I'm a clinical psychologist at Cognitive and Behavioral Consultants of Westchester and Manhattan. And at CBC, I am the director of the trauma-focused treatment programs, where we provide evidence-based treatments to those who have trauma and all of the sequelae of trauma that occurs for people. And we also provide a lot of training within in-house to our psychology externs, as well as interns and postdocs. And we also consult a lot to the communities in our area, the schools in our area, as well as other businesses and clinicians who are interested in getting more consultation on different evidence-based treatments. So that's a little bit about my role, and I'll pass the baton over to Lata and Will to introduce themselves.
Go ahead, Will.
Sure. So I'm Dr. Buerger. I'm also a staff psychologist at CBC and one of the trauma program supervisors, and assist Lauren in most activities, reaching out to the community and whatnot. And happy to pull this together.
I'm Lata McGinn, and I'm the co-founder of Cognitive and Behavioral Consultants and also a professor of psychology at Yeshiva University. So I'm so excited to be here to share with you guys, how we can help ourselves and others in the middle of the pandemic. So thank you for taking the time out of your day to join us.
All right, next slide. Awesome. So today we really want to focus on defining trauma as it connects to defining trauma, but then also like helping us understand how that connects to the current pandemic, and how is it that there are people that are experiencing trauma as it relates to the pandemic we're in right now. We really want to emphasize resilience and common reactions as it relates to this situation we're in, which leads nicely into actually talking about psychological first aid. What does that look like? What do we have control over doing right now to help prevent people from developing symptoms such as PTSD or disorders such as PTSD? And within that, we really want to emphasize how do we adapt it to the current crisis. So we're going to give an overview of PFA. We're also going to make it really specific to the current pandemic, so that it feels like you have some tools that you can walk away with after the hour. And then we'll spend a little bit of time at the end just talking about, well, what do we do if this is not enough, so that you feel prepared with how to make recommendations if you're recognizing that the people you're working with are needing more assistance. So that's kind of the objectives for today. I also just wanted to acknowledge that there's a lot of people here today, and as a result of just the sheer number of people, I would imagine that it's inevitable that some of us are also experiencing loss and stress as it relates to this pandemic. So I just want to, say that our thoughts are with you, and that this applies to all of us. So not just the people we're working with, but it really impacts us too. And so we're here to support the whole community, including you all. So I will pass the baton to Will, who's going to start us off today.
Sure. Thank you, Lauren. So we thought a helpful place to start is to talk about what specifically is traumatic about this pandemic, and to step back even further, kind of what is trauma? Because trauma is a term and a concept that has started being used very widely, kind of a lot of colloquial uses of this being traumatic or that being traumatic. And in some ways that detracts from what we might be thinking about when we're looking at how to treat it from a psychological perspective. And, the intention here is not to make us arbiters of what is trauma or is not trauma. That's unhelpful and potentially invalidating to kind of be telling clients that they're using terms incorrectly, but instead that regardless of the debate around the utility of DSM criteria, these are identified experiences that are going to lead to particular distress, and also that we have a lot of research showing what can help in this regard. So to go back to kind of these criterion A definition, we're looking at exposure to actual or threatened death, serious injury, sexual violence in one of these ways, right? Directly experiencing, witnessing, learning about it, occurring to a close family member or close friend, or experiencing repeated exposure, although of course you kind of want to pull out exposure through the TB. And so these are the criteria we're all very familiar with. What might jump out is, of course, that this experience is going to kick up a lot more criterion A traumas. The most obvious are family members dying, learning of family members dying. But also something to hold in mind is that other kind of traumas secondary to COVID might be kicking up. You know, people are suddenly locked in their homes or encouraged to stay at home with family members, and you might have increased traumas, victimization in that regard. So a lot of different ways that this experience is actually exacerbating a lot of those. Now, as people are exposed to these traumas, as you guys all see in your work with your clients, you see a range of different reactions. And it really is a range, right? I mean, as you can see with this busy slide, there's a lot of different kind of emotional reactions that get kicked up. You're seeing startle responses, changes in appetite and sleep, changes in cognitions, you know, fears, feeling judged, looked down upon by others, increased anger. And one of the ways that I kind of try to think about this is that what's happening with trauma is that the mind and the body are suddenly exposed to an experience that really jars your understanding of reality, right? I thought the world was one way, and it is now shown that that is not the case. And so you're seeing a lot of emotional, cognitive, behavioral reactions that are trying to kind of adjust to this new world that they're living in. And a couple of COVID-specific reactions that you might see are, well, the first one is, of course, going to be traumatic grief. You know, grief is, again, it's a natural part of life, right? Death is kind of the dialectical opposite of life, and tolerating that, understanding that is something that all of us have to go through. And as we all know, that it's a very difficult process. And regardless of whether we want to define that as a mental health problem or instead a natural grieving process, one of the things that the data does show is that certain kinds of loss are particularly difficult to tolerate, are particularly difficult for the mind to digest and absorb. Deaths that are unexpected, deaths that seem to occur without reason or not in the ways that one's anticipated. The mind really reels with those because it's particularly jarring. And the way that the world looks now and just the number of deaths that are so great that they kind of defy comprehension, I think a lot of us can relate to that. And I, to Lauren's point, my thoughts go out to you if anyone listening now can identify with that. The second is this idea of moral injury. To return to this idea of trauma being about your understanding of the world suddenly being jarred, one of the things that can be kind of knocked off track is our understanding of morals, our understanding of values. You know, we kind of approach life with an understanding of how things should happen. And when that doesn't occur, that's a unique kind of suffering. To make this a little concrete, you know, I think we'd all like to believe that with our loved ones, you know, as life ends or nears an end point, that we'll be able to spend time with them. You know, a belief that if someone I love is in the hospital and suffering, I should be there to support them. Well, on a massive scale, that's no longer allowed. And so that's just one example of how that kind of moral injury can create a particular kind of suffering. Compassion fatigue. I probably don't need to expand too much here. I mean, right? I mean, all of you are being required to express a great deal of compassion, empathy during a time when your resources are very taxed, right? I have my team on Fridays, and I used to sometimes take vacation days on Fridays, get a head start on some travel, and I have not done that and do not plan to do that because I kind of need my team on those days. And so, you know, being very mindful of the impact this is having on us, the kind of vicarious traumatization this can have on us. Generalized anxiety and worry. You know, the mind has a different way of worrying about things. It can get very focused on some things. How are people perceiving me? What's going to happen with this job? And then there's that kind of generalized form of anxiety, which is a little bit more, well, this is suddenly outside of my control. You know, in an overarching sense, I don't have a control of what's happening in my life and what's going to happen. And And that's discomforting to me. Well, that perspective is no longer all that pathological, is it? I mean, the reality is that none of us quite know what's going to happen. And so I'd anticipate a little bit of an increase there. Stress, sadness, secondary to major life changes, as I was alluding to before, you want to be mindful not only of the direct impact of the virus on loved ones, but also the secondary impact it's having as life changes, right? People lose jobs, families restructure, whatnot. Okay, so that's kind of the bad news. What's the good news? Well, a lot of the data shows that as these symptoms come up, they also remit, right? About 2/3 of individuals exposed to a trauma, you're going to have an acute trauma response that will abate over time, right? Most individuals, I think the data shows you're seeing these symptoms remit over about a period of a year. And it's really the minority of individuals that are going on from a acute trauma response into what we might call PTSD. And that even those who develop PTSD, the symptoms generally kind of remit over time. So what is the suggestion here? Well, I think that the idea here is not for us to tell you guys, don't worry about it, it'll sort itself out. But instead that the mind and the body have a tremendous capacity to repair themselves. This isn't unlike in physical medicine, right? If someone breaks a leg, what do? You put a cast on it. Well, the cast isn't going in there and restructuring the bone. What it's doing is it's setting an environment that can hold it and provide a structure so that it can repair itself. And I think that's a little bit of a way to think about trauma in the immediate term, is that the mind has a tremendous capacity to repair itself, and we want to set up a holding environment, a form of structure that can encourage that to occur. So how to do that? Well, we'll start with what not to do. So critical incident stress debriefing. Okay, so this is an intervention that I believe was created around the early 80s. Really actually created for emergency care workers, not actually victims of trauma, but it was 24, 48 hours after the trauma, looking at providing information, education, emotional processing of the trauma. Let's talk about what happened. Let's talk about what you can expect to occur, what the mind is doing, what PTSD is. Okay, now in intuitive sense, this sounds like a very good idea. This actually sounds like a lot of our trauma treatments, a lot of the exposure-based or narrative-based treatments that we might do. It's kind of following a very similar structure. And so it would make sense to suggest that this would be a good thing to get a head start on. If it's going to work later, well, we might as well get it going early. One of the things that the data showed, though, this is a little bit, I think early 2000s, a lot of data started pouring out that, this approach is actually, at best ineffective and at worst potentially harmful. A lot of studies showed that when you took this intervention with people who had just experienced trauma, rates of PTSD actually increased, which is, needless to say, not the outcome that we were looking for here. And there was a couple problems there. One, it's way too soon. We're not looking at the months following trauma, that time period during which this recovery is happening. You're looking right in the moment. This was also a group intervention, so a lot of these groups were unvetted. People were engaging in exposures with people that they weren't comfortable sharing with necessarily and weren't matched appropriately. But I think the other bigger difficulty here is that you were kind of planting problematic seeds, saying, hey, this might happen, that might happen, this might happen. And also encouraging people in a moment where a wound hasn't set to kind of dive back into it and engage with these really painful emotions. And so, to go back to the cast metaphor, I mean, it's a little bit akin to, we have a lot of physical therapy ahead of us on that broken leg, so let's get you moving while you're in the cast and get a bit of a head start. I mean, that's ill-advised and tremendously harmful, actually. And so you don't, in that immediate term, want to start this kind of treatment. So what that means is what we don't want you guys doing, or what we might suggest, is to take this approach of, assuming that people are going to be experiencing PTSD, suggesting or pathologizing and going in the direction of this is surely going to be very, very hard for you, right? It's statements that are so natural and well-intentioned and can feel validating, but can actually kind of be setting us off in a tricky path. So not going towards, symptoms, diagnoses, not judging, predicting, or really diving into the emotional content of the therapy. You know, talk to me about what happened. Talk to me about how hard that felt and where you felt it in your body. You know, that's really not the direction we want to be going right now. Now, of course, given a lot of feedback on what not to do is also, you know, somewhat ineffective feedback. We also have to give some direction on what to do. And so for that, I will pass it off to Lata.
Yeah, so I guess let's you know, talk about what to do. So some of the things that Will has gone over, you know, about what not to do comes from the literature on CISD, that it's not helpful, and some of that comes from psychological first aid. So what is psychological first aid? It really is something, as Will was describing, that is there to just help in that moment. It's an evidence-informed modular approach. It really is built on the concept of human resilience. It comes from the research on risk and resilience. It comes from research on the progression of untreated trauma and how people react. It also comes from the history, the combined sort of military history that we have in treating vast amounts of people who have suffered through trauma. And what it basically shows that people actually recover, not only that they recover, but that they do so without any specialized interventions, which is really good news. So it was developed as a way to help children, families, adults, you know, older adults who have suffered through, you know, either disaster or personal traumatic incident. And it could be first responders or just survivors or witnesses, with the idea that there is something abnormal has happened, and that in reacting to that, we might struggle or face new challenges, or, you know, following the event. So the goal is really to facilitate natural recovery. And I want to say that again. It really is to not impede natural recovery, but to actually facilitate it. So it aims to reduce symptoms, stress symptoms, and you know, helps you recover. And that as you manage that initial distress, it helps you with sort of long-term functioning, but in the moment, short-term functioning as well. So well, you could move that, yeah. So what we're going to focus on is adapting PFA during the pandemic. And so that's our focus today. So how is it different? And there's a couple of differences, right? So one is most of us, except for healthcare workers, are working remotely. So one way that it has to be adapted is for it to be remote. And the other thing is that PFA was initially intended to be in the days and weeks after a trauma. But as we well know, this trauma is ongoing. So typically, psychological first aid is what you would administer in the days and weeks after, and then you would move on to skills for psychological recovery in the weeks and months after. So we are in this sort of nexus where we're kind of still going through that first phase. So those are a couple of the ways that it is different. So to do it remotely, you can use the manuals to sort of do it in over the phone or a web-based platform. But again, the goal really is not to do therapy, not to do treatment. It really is to provide comfort, support, to let people know that their reactions are normal, to help them calm down, to do some problem-solving skills. You know, to help them, even so you, as you're dealing with somebody's feelings and behaviors, you're going through your own emotions and feelings. So this also helps you regulate your own feelings and behaviors as well. And certainly with the idea that PFA is not for everybody, and that people who have more severe symptoms would be referred for additional treatment. So now there are core actions in PFA. Now, when you look at the literature and you look up manuals, you will see that sometimes they might have a different acronym. So for example, the World Health Organization has an acronym, you know, called Look, Listen, and Link. And so as not to confuse you, really what the core really is that no matter what it is, there really are 8 core actions. And so those are what we're going to go over. And I'll touch base on how it actually is used usually in the case of in-person PFA, and then, you know, make reference to how we would use it in the pandemic. So we'll go over all 8 actions now. So we'll start with contact and engagement. And what that really means is that you have to reach out, right? So this is not necessarily intended only for you if you're a mental health professional dealing with your client, but it could be that you're actively reaching out to your friend or a family member or someone you know that is in distress, or that you're responding to someone who has contacted you. The way that it was intended, obviously, PFA, when you're going through, let's say, a hurricane has happened in a neighborhood and you're going there to help people, the idea is that you're going up to survivors and how to actually engage them in a way that it's helpful. So the most important part of this is that you have to be non-intrusive, and that you're not going in there assuming that they need your help or assuming that they don't need your help. The other thing to focus on is that there might be several problems the person is dealing with now, in the future, and they're overwhelmed. And so your goal is really to narrow it down and focus on really the immediate pressing problem. What can you focus on today, and what is most urgent today? So now your own demeanor, as we'll move on later to the next slide, would be about safety. So, well, you can stay in the first slide. But your demeanor here is to be calm, empathic. So you're already starting the process of creating safety for the person. You're giving them your full attention. Now you're working from home. You might be having, ambulances going by and hearing the siren. The person that you're talking to might have kids running around. And so the goal is really to give them your full attention, to be compassionate, to be helpful. And there are lots of cultural norms that PFA goes over in terms of being sensitive to the person's culture, in terms of how they may react to trauma, how they may experience trauma, and so on. And of course, what you're trying to convey also is that what is being shared with you is confidential. So moving on to the next core action, once you've now made this contact and engagement, you're now there, not only in your demeanor, but your goal is really to enhance that sense of safety and to provide support. And ways to do that is first just to acknowledge what is going on. And you are opening up a space so that people feel comfortable sharing with you their worry, their anxiety. They might have concerns about their safety. They might have lost someone. They might have a family member working as a frontline worker. They might have, feelings of guilt about their situation, feeling shame. So you're communicating really here that not only is it acceptable to share, but that you're conveying with your listening and empathic skills that everything that they're telling you is normal. And so it is normal to feel these emotions, it's normal to feel these reactions without any judgment at all. So your goal is to, as you're conveying this interest, this availability, you're listening fully, you will be pulled upon to provide information that might be there to help them feel a sense of safety. And the important thing here is not to go beyond the scope of your knowledge and to provide accurate information about maybe what is being done to keep everyone safe, but being honest if you don't know, and making sure that you're not going beyond that scope. And how much you share also depends on the developmental needs, meaning how young is the person that you're talking to. But overall, your goal is to let them know they're not alone. Now, when you're providing that safety, you're working in the field and you're going up to somebody, you can definitely provide a lot of physical support. So for example, you might be, walking up to somebody who has lost their glasses and you are helping them find their glasses. So something really practical. But if you're working remotely, you could still facilitate some degree of physical support. So let's say a child is, missing school and missing their teachers. So to create an environment where they arrange their desk or put down games or colored paper or posters or a bulletin board that helps them feel like they're around something familiar, something that creates safety for them. And of course, you're offering emotional support. So moving on to the third core action, after you've done, maintain that contact and engagement and providing a sense of safety throughout, For some people, you might be encountering people who have very intense reactions, and sometimes they can be distressing to you watching that person, and you might feel helpless in terms of how to help someone who's that upset. So the third core action is, if you need, you can help stabilize them. So the goal of stabilization is really to calm someone down, to ground someone who's feeling emotionally overwhelmed, disoriented. And so, in the beginning, of course, just by being that calm demeanor and being quiet and non-intrusive, you're already facilitating that. You can normalize their emotions and provide some brief education to help them not feel like they're going crazy, indicating how support from you and others can help. But then let's say if the intensity of the emotion is higher, you can help orient them, where are you right now? You're talking to me, what's going on in your surrounding, helping them describe things in the present tense. And then there are breathing exercises that you can do to help them calm down. One of the one sort of common grounding techniques that we use, will take us to that link now, is essentially sort of activities that help activate your senses and bring you down. So what these grounding techniques have in common is really that they bring us to the present.
This technique will take you through your 5 senses to help remind you of the present. This is a calming technique that can help you get through tough or stressful situations. Take a deep belly breath to begin. Number 5, look around for 5 things that you can see and say them out loud. For example, you could say, I see a burger. I see a bird. I see a soccer ball. Number 4, feel. Pay attention to your body and think of 4 things that you can feel and say them out loud. For example, you could say, I feel my feet warm in my socks. I feel the hair on the back of my neck. Or I feel the pillow I'm sitting on. Number 3, listen. Listen for 3 sounds. Say the things out loud. It could be the sound of running feet, an airplane flying by, or the sound of a dog barking. Number 2, smell. Say 2 things you can smell. It's okay to move to another spot and sniff something. If you can't smell anything at the moment, or you can't move, then name 2 of your favorite smells. Number 1, taste. Say 1 thing you can taste. It may be the toothpaste from brushing your teeth, or the flavor of your bubble gum. If you can't taste anything, then say your favorite thing to taste. Take another deep belly breath to end.
So that's just one of the techniques that you can use to calm somebody down. Now we're going to move on to core action 4. So at this moment, your goal is to sort of identify those immediate needs that we talked about, to gather information so you can tailor what you're about to do. What kinds of coping methods might you use? So your goal is to gather more information. Their experience might be very different from yours. Have they developed COVID? Has a loved one developed symptoms or passed away? Are there other losses that they're experiencing? What concerns do they have? So, identifying personal and commonly experienced reactions. And obviously, if you're working as a mental health professional, you're also going to be, assessing for suicidal, homicidal ideation, intent, how much substances are they using, and so on. But essentially, your goal is to really focus on what do they need today. And you're combining sort of providing that information and in thinking in your head about what practical assistance can I provide this person in this moment, and summarizing and prioritizing their needs to sense their sense of being overwhelmed because they might have multiple needs. So as you move on from information gathering, your goal is really then to offer that practical assistance to address those immediate needs. So you can clarify that, and working remotely, your goal really is to discuss a plan that is realistic, it's practical, and it's actually achievable because you want them to have a success. There are so many things that are out of all of our control that we cannot do. So what is it that they can actually do in the moment? What is a small thing they can do? And then guiding them to take those steps. And the key here is to use the person's strengths, how they've behaved effectively in the past, what they might have done in the past to contribute to helping others in need, and how they can use those skills to help themselves. And so as you work on that practical assistance, the focus of PFA is really that Band-Aid that we spoke about, that you are helping them come up with ways to help themselves today, combined with that connection with support. So now we know from research that the biggest buffer of mental illness is support. So your goal is to establish some brief or ongoing contacts. It could be with primary people, but you're emphasizing the types of support. So they might not get the same type of support from everybody, but identifying what kinds of support they need and then linking them to different people who can sort of provide that support. And emphasizing that physical distance can remain and social connection can still be present. So helping them establish their connectedness, whether it's with families, spending time with them in terms of games, doing artwork, playing music. It could be even working on home projects or chores. Offering them tips to sort of promote online interactions, or in my case, asking your teenage daughter to help you figure out what kinds of online interactions can be, maximized. So for example, you can watch Netflix and chat with somebody while you're watching Netflix, as an example. But the key here is to emphasize that both seeking of the support and offering of the support is equally helpful. So that, we know from research that if you help others, it can actually have an antidepressant effect on your mood. So you're getting support and you're also offering that support to others. So moving on to core action 7, you are now providing them with some information. Now, again, you're not doing therapy, so you're not necessarily training them to modify their emotions, their behaviors, their cognitions, but you're providing them with that information on what a stress reaction is. You are educating them about what are common reactions to adversity that Will went over in the beginning, figuring out sort of situations for them that create stress, when they hear an ambulance, in the morning when they get up, or in the evening when they're about to go to sleep, or when they read something in the media. And figuring out, giving them that basic psychoeducation on stress, that, when you experience danger, your heart beats faster, and then, you might be sort of reading the news over and over again, and helping them see that what they have control over right now is the kinds of things they do. And so we'll be going over, and Lauren will be going over ways, that behaviors that you can use to cope adaptively, but you're helping that process here by talking about it. And then you're teaching them these basic skills. So you might then first sort of look at their belief system. So one thing we know from research is that people who have not experienced that much adversity, they might, have come into the world having lots of benign, thoughts about the world. Things have really gone their way, and life is fairly predictable. And for people who have that, and let's say they're pre-existing beliefs before something traumatic happens, if it's particularly positive, or on the other hand, particularly negative, those are the clients we normally work with, that more PTSD should result. So you're sort of listening to that, and you're sort of gathering information to figure out if the person that you're speaking to, where they fall on that spectrum. You're also listening for other unhelpful beliefs that we know make people really put them at risk for developing PTSD and other symptoms. So we know that for people who have excessively negative interpretations of trauma, the effects of the trauma on themselves and others in the world, they might even doubt how they behave during the traumatic event. I'm weak, I shouldn't be reacting that way, I shouldn't have these symptoms. And even people who really, are unhappy with others in the aftermath of events. So if they feel like people are not there for them, my mother didn't support me, or, what is the government doing? that actually has an impact on your own mood and own impact of whether or not you develop PTSD. We also know that the more you think something traumatic sort of impacts you in all your life domains, it actually has a greater impact. It becomes sort of like a self-fulfilling prophecy, where the more you worry that it's going to impact everything, the more likely you are. So you're listening for these kinds of beliefs as you're listening to the person. So moving along, people who sort of, here's the thing. We are essentially going through something traumatic today, right? Something it's fairly, all of us are in it, and there's certainly negative outcomes that we're all predicting. I'm sure all of us are engaging in catastrophic thinking. However, one thing we know is that if we keep ourselves in a steady, heightened state of danger, where we feel like there's a lion in the room with us today going to eat us, that is actually, that steady state of anxiety and threat can actually make it worse. So it actually makes your mood worse, makes it more likely that you will develop symptoms. So as you're listening to the person, you're trying to sort of understand how they're viewing the world. Do they assume that this is never going to end? Do they feel hopeless about the world? And the key here really is, do they feel that the impact of what's going on today is permanent and negative? That the world will never be the same again. And the flip side of that is they feel incapable of coping with it. And that's what you're listening to. So quick sort of a slide on how our minds, emotions, and actions sort of have power. We know that if you have thoughts of danger, it can lead to heightened fear, and the urge is to sort of get away from danger or fight it. If you feel that somebody is doing something to you unfairly, or your personal rules have been violated, you feel angry and feel like attacking. You might get irritable, angry. If you feel like you're responsible for something bad happening, you feel guilty and you try to make repair. If you feel like you did something wrong, you violated an important standard, you can feel shame. And if you feel like you've experienced a loss, you feel sadness and you have the urge to sort of withdraw. The reason I bring this up now is really so that you understand that all of it has a function. So when you have thoughts, they have a powerful impact. So on the one hand, what are you going to do? So on the one hand, you are normalizing and promoting acceptance. So no matter what they're feeling, you're accepting that their emotions are normal. You're also conveying that trying very actively to suppress how you feel and to suppress what you're thinking is not really helpful. So your goal on the one hand is to really empathize that what we're all going through is real, our suffering is real, and it may have had a huge impact on their lives. It could have affected their, graduation, birthdays. My daughter's back from college, she's a freshman. It has affected her trajectory. So people have had their weddings postponed, and of course people have died, and there's so much that could have happened. So you're empathizing and validating on the one hand, and yet the balance really is, on the other hand, what you're doing is that you are trying to make sure that you are balancing that with optimism. So we can move on to the next slide, Will, where your goal is, so what we've learned from the historical military experience is that when you provide safety and support, all the things that you're doing to help today's needs, the key here really is that it has to be done when you give them the expectancy of improvement. What we know through research is that people are very vulnerable when they're under stress. So if you communicate to someone when they're under stress that PTSD could develop or something bad could happen, they're actually going to take that in a deeper way than if they were not vulnerable. And so providing them with that expectancy of improvement is really the key here. So you are fostering those beliefs that what you're experiencing is normal, but it is temporary. The world will recover. And you're just helping them see that the impact may not be permanent. It may not be forever changed. And in fact, things could come from it that might be positive in the long term, that there might be some psychological growth that comes from what is going on. So that's one, to make sure that you are fostering optimism. The other is that you are fostering sort of benign perception. So we know, again, from research that the more you think that what you're doing is negative and what other people are doing is negative, and that if you don't feel like you're coping, it actually winds up having a self-fulfilling prophecy. So the more that you can foster sort of benign perceptions of themselves and give other people the benefit of doubt, they're doing their best. Everyone's doing their best, and we're trying to cope the best way we can. So it's a matter of balance. We are not invalidating that something bad is happening to us, but that you're offering just balanced, positive thoughts that, one day it might take some time, but, we will get better. Things will get better. So there's a link over here, but I think for the sake of time, we'll sort of move along. But ultimately, I'm going to leave it over to Lauren so that she can focus on what kinds of behaviors might be helpful to cope.
Okay, I just want to acknowledge there's a couple questions that came up that I thought were really relevant, so I wanted to address some of them. One is particular to other therapies, I'm using that word lightly, that are being presented out there in the community that are being spread as potential treatments at this time that might actually be iatrogenic or not helpful at the very least, and beyond just CISD. And I think behavior or treatments such as tapping or, somatic experiencing. There's a little bit, at the very least, we know that those things aren't appropriate for acute stress. I think the jury is still out on PTSD. I know that there's some, minor or basic research that's coming out specific to that, or like the beginnings of research that's coming out. And yet those aren't the evidence-based treatments that we know have the most data to support their efficacy for PTSD. And at the, sort of taking a step back, like right now we're not treating PTSD, we're talking more about the acute stress. And for that, we know that PFA is really what's recommended. So if, it's just important to be aware that there are other treatments that are out there that are being, spread as effective therapies right now that are actually not based in the research and the data of what to do right now. So that's one thing I wanted to comment on. And then I think another concern is, we're saying it's important to not necessarily go in and share all this emotional experiencing right off the bat, because that's one of the components of CISD that could be problematic. But at the same time, what if you're having a session with or working with someone who is wanting to share and expressing the details of their experiences? Is that something that you shouldn't encourage? And I think that one of the elements of CISD that made it iatrogenic was the group component of it, and having to share these experiences with your coworkers, and with, that's how these groups were formed, with people who might, not be having a trauma reaction in the same way that you're having a trauma reaction. And so I think if individually allowing people to have that space to open up and share what their experiences are without pushing it, right? If they're saying, this is what's on my mind and I want to share, absolutely. I think allowing that process to naturally occur is for sure recommended, versus sort of giving them the message that they can't, go there right now. So I think it's this balance, right? We're not saying like, you have to do it. Like, tell me everything that you're experiencing right now, while also being a safe space for them to be able to share those experiences and those emotions when they pop up, if they pop up. So those were great questions. And I don't know if Lata has other thoughts specific to that.
Yeah, I think as Will was pointing out, I think it's also a question of timing, right? When someone has just gone through trauma,
Right.
Your brain is sort of helping you absorb that shock and piercing through it, and insisting that somebody relive traumatic experiences is not helpful. When we use it in cognitive behavioral treatments, it's done at an appropriate time and done systematically. So by people who are trained in it.
Right. Exactly. Thank you. Just want to make sure to screen share. So jumping in with more of the the behavioral side of things, I think really thinking about, you know, the point where sort of what we were just talking about is that ultimately avoidance as a strategy doesn't work. And so if on the other side, we're, you know, I think it's important to think about what does it actually look like to avoid? What does it look like to be actively pushing away? And I think, you know, that a lot of times it happens with various behaviors that end up suppressing emotions that can be really problematic, such as substance use, you know, alcohol or other substances, as a way of coping, as a way of actively pushing away emotions. That can be, you know, problematic. And I think, again, I think all of this is to say some of these reactions are to be expected, right? Some of our common reactions to like not want to be thinking about it or to want to avoid reminders. And yet I think it's the degree with which we're commenting on it being unhelpful, right? If it is total and complete avoidance, total and complete denial, really active pushing away of reminders, and emotional experiencing, that's when it can really be problematic and could inadvertently end up making it more likely that someone will develop PTSD. And of course, on the extreme end, there's you know, extreme ways of displaying emotional avoidance, which a dissociation is, you know, one example of what that could look like. So another, you know, just thing to be mindful of and aware of in the people you're working with. I think you know, beyond just avoidance, there's also structure and things that other self-care, other behaviors that can start to go by the wayside as a result of being in this current pandemic. So lack of structure, lack of routine, not sort of following your sleep hygiene, not following self-care, like eating a balanced diet and working out when you can. Obviously, like a lot of these things are going to be harder to do given the current circumstances. And if there are small ways that you can be encouraging the people you're working with to start to build this in, it can be helpful as a way to undo some of the impact or prevent some of the impact of this trauma potentially causing more damage in the long run. I think positively reinforcing activities. I think this is this is like true of any, you know, trauma situation, that there might be you know, anhedonia or difficulty being able to experience positive emotions, not wanting to do things that used to bring up positive emotions, on top of the fact that we are all stuck at home. We all, you know, a lot of us have less opportunity for positively reinforcing activities, right? It's just going to look different right now. And so I think that's just an added layer to really be mindful of and aware of. What are we suggesting that people, you know, do right now when they are at home? What do we have control over? Really focusing on that piece of control that we do have. So I've mentioned a lot of this already. I think this second bullet is important too. This, you know, Lata was mentioning it as it relates to physical safety. I think we want to be assessing that people are taking the appropriate safety precautions, as well as not exposing themselves to more psychological harm with excessive media exposure. I think that's really important to be assessing as well. And doing what we have that's in our control. I can't say that enough. I think there's a lot of feelings of helplessness that I've been noticing in the people that I'm working with, and also within my community of psychologists that I work with. And I think really, you know, taking a step back and focusing on what control do we have, and let's really put our focus on that. So mastery, right? So not just pleasure, but really how do we build up that sense of accomplishment? What can you do? What can I do to make myself feel accomplished, right? Can I donate food to the food bank locally? Can I send letters to elderly folk who don't have ability to get visitors right now? Like really thinking about ways of contributing and ways of feeling accomplished with what's within my control. Reminiscing, right? If there is someone who has passed away, then that is something that is within your control. It is so sad to hear about how funerals are having to happen via Zoom right now. And, you know, I've heard about people not being able to pay their respects in the ways that they would normally be able to. And I think that's really sad. And so thinking about, okay, I can't honor that person in the way I typically would. So how can I, right? What do I have control over right now? And so that's a really important piece to acknowledge. And, focusing on the support piece. I know we're sort of repeating some of what we've said already, but I think it's so important just to recognize how important that social piece is. It's one of the biggest predictors of lack of social support is one of the biggest risk factors for PTSD. So really thinking about that piece and assessing, like, what do they have access to right now? Are they quarantined with people that they find supportive? If not, who are those people going to be? So really thinking outside of the box with being able to still provide these recommendations, these positive behaviors, the positive social supports, even though we're in a scenario that is more challenging. We will be sending out the slides, so you'll have an opportunity to get these links. But we just wanted to make sure that you were aware that there are a lot of resources out there specific to PFA and handouts that were adapted for COVID-19 that are being put out by the National Child Traumatic Stress Network, so NCTSN. There's a lot of great resources there. There's also something that the NCTSN has, I think it's like an 8-hour training on PFA that normally costs money, that right now they're it's available for free. So I just wanted you guys to know that exists as well. Because of course we're going over the broad strokes, but really if you want more in-depth training on this, then there's opportunities for that out there. So moving on to thinking about, okay, and I know there were some questions related to this as well, as far as, what do I do? When do I suggest a higher level of care? So that's one, point that I'm going to get to now. But then also, what if I'm currently doing PE, CPT? Do I pause the treatment? Do I continue? I had some people asking that question, so I wanted to address that as well. So, obviously we know that resilience, as we've been mentioning, is the most common outcome. And at the same time, there's about a third of people who will go on to develop various symptoms, not necessarily PTSD only, but, there's other, symptoms or diagnoses that can come about as a result of trauma. And so I think, keeping your radar open and assessing for if there are clinically significant symptoms, if the timeline, if it's not just a month now that they're going through these reactions, but now it's many, many months that they're experiencing these symptoms, or I guess at that point, right, you can call them symptoms and not just common reactions. Or if it's been more than a year. We know that after a year, if trauma symptoms aren't gone away naturally, at that point, they're unlikely to naturally go away without intervention. So assessing for those things, as well as if a person has particular risk factors. I think this last bullet, though, is interesting, right? It's those who request treatment. So if it's within that time frame, if it's within that year, even though that, there's a chance that these symptoms will naturally go away, if someone's really suffering and wanting treatment, by all means, provide the treatment. So I already mentioned this. Just some risk factors to be aware of, right? Thinking about the people you work with, if they have one or more than these risk factors, then they're more likely to go on and develop longer standing symptoms. And, again, important. I think I added this sub bullet under type of trauma to really highlight that I think Will mentioned this, one of the types of trauma that is a higher risk factor is fear of your lives, and then also observing a serious injury or death of another person who's, another person in your life, especially a loved one. So if we're thinking about the kind of traumas that we're being exposed to right now, fear for your own life. Some people might be experiencing that, especially if they're on the front lines in hospitals, nurses, doctors, they're more likely to be exposed. Or death, right? If someone that you love has died, there's a higher risk factor there. As I mentioned a minute ago, PTSD is not the only outcome that could occur as a result of trauma. There's other disorders, other conditions, just to be aware of, and not sort of being too narrow in your assessment to recognize that there could be other reactions. Lata did mention this, psychological skills for recovery. It's more of a secondary prevention model. So not just a universal frontline approach, which is what PFA is. This is, it's now been weeks and months following this trauma. And if there are, in a community, whether it's in a school or a group of people, you can provide more skills building as a way to make it less likely that they'll develop further symptoms. So, and the evidence shows that skills building as an approach is more effective than supportive counseling in most situations. So I guess to finish off we have 3 more minutes. I wanted to comment on the question related to treatment and what do you do if you're actively doing trauma work right now, and then all of this has happened. This question has come up a lot on the trauma team that I supervise and consult with, and I think what we've really been taking it case by case and really thinking about what are the most immediate needs for this person right now. Do they have the ability to emotionally process right now? Does this still feel amongst everything that's going on? Does this still feel like the top target for treatment? Are they in a safe space to do this work? Right? If their trauma relates to someone in their family that normally they don't have to be around all the time, but now they're quarantined with that person, again, like, is that now safe? Is that a situation that, do we want to focus more on building up their coping skills, their resilience, a la PFA, or do we want to sort of continue the work that we're doing? So I really think it's a case by case, but as long as you're really reflecting on what, the decision process that you're making and asking yourself those questions, I think, you'll be good to go. Ultimately, there's no reason to think that you can't continue to do PE or CPT if that really is what's indicated at the time. So I just want to encourage you guys to keep doing that work if it does make sense. So these are, as I mentioned, PE, CPT, these are as well as cognitive therapy for PTSD. Of course, if there's more complex PTSD where there's other diagnoses involved, there's other approaches that are out there. STARS, DBT, PE, seeking safety, and others. For youth, just want to always, acknowledge that there are other CBT-based interventions that exist for youth. And we at CBC are, recognizing that there is going to be a big influx of trauma, and we really want to make sure that we're providing resources for the community. So we are in the works of creating both an adult training and a child training in order to provide these evidence-based treatments to those who want to get more specialized training in both prolonged exposure as well as trauma-focused CBT. So I think that's all we have for today. We are so grateful that you guys could be here with us and learning about PFA. And yes, we welcome any questions. You can always let us know, shoot me an email, which should have been on when you receive the email about signing up for this. My email is on that announcement. So feel free to reach out, and take care, everyone. Stay safe.
Yeah.
Thank you very much for joining us and letting us go over skills. Thank you so much.